Diagnosis of complex febrile conversions. Complex febrile seizures always require specific investigation, e.g. imaging, last longer than 15 minutes, have more than one seizure within 24 hours, focal onset pronounced on one side of the body, transient speech impairment, and hemiparesis also determine cause of fever as in a simple febrile seizure. Also perform lumbar puncture to exclude meningitis and herpes encephalitis, EEG, imaging, CT or MRI. May not clinical but always need EEG and imaging focal onset pronounced on the one side. Transient hemiparesis, speech impairment more than 15 minutes, more than 1 per 24 hour. Typical age is not between 6 months to 5 years. Febrile seizures are considered complex if one criteria is met. Complex febrile conversion, also known as complex febrile seizures, are a specific subtype of febrile seizures that are characterized by their prolonged duration, occurrence within 24-hour period, or focal and Julia system. They are associated without underlying central nervous system fiction diagnosis based on history and presentation. Here is an overview focusing on that diagnosis. Characteristic symptoms and pathophysiology. Symptoms: seizure associated with fever, 38-degree or without evidence of intracranial infection or defined cause, and duration less more than 15 minutes. Recurrence may occur within 24 hours. On the same febrile illnesses and focality, people can have focal onset or features indicating specific lesion of the brain is initially involved. Pathophysiology, the exact mechanism is not fully understood, but involve interplay between fever-induced changes, neurological excitability, and a genetic predisposition of seizure. Clinical presentation and diagnosis: history, detailed account of the seizure, including onset, duration, and any focal features, information on the level of febrile presented illnesses, and family history of febrile seizures or epilepsy is crucial. Physical examination assessment to rule out signs of central nervous system infection, meningitis, and to identify the source of fever. Laboratory tests, blood tests including electrolytes, blood glucose, and complete blood count to exclude metabolic causes, and lumbar puncture. Meningitis is suspected, especially in infants who are the child appears very ill. Neuroimaging, MRI, CT is not routinely recommended, but it may be considered neurological examination if abnormal or seizure focal. Which is not typically used for diagnosis in acute setting, but might be considered in atypical cases to rule out an underlying epilepsy syndrome. Treatment: acute management, seizure management with antipyretic to manage fever, and if necessary, rescue medication for prolonged seizures such as letrodiazepam or carbendazole. Long-term management now usually required unless there is underlying neurological condition or epilepsy symptoms. Prognosis: risk of recurrence higher in a complex febrile seizure compared to simple febrile seizure. Development of epilepsy slightly increased risk compared to general population, especially if there are focal features of family history of epilepsy. So the differential diagnosis table: condition: simple febrile seizures, shorter duration, 15 minutes, no recurrence within 24 hours, generalized, and epilepsy. A seizure without fever may have chronic pattern. Meningitis, encephalitis, sinus, meningeal irritation, or telemental status may have seizure, but fever are not the sole cause. Electrolyte imbalance, history of vomiting, diarrhea. Seizures not necessarily associated with fever. High opioid complex febrile conversion are characterized by duration over 15 minutes, recurrence within 24 hours, or focal feature. Diagnosis is primarily clinical, supported by history and physical examination, with investigations aimed at ruling out other causes. Long-term anti-epileptic treatment is not typically indicated, but the risk of recurrence and subsequent epilepsy is slightly higher than in simple febrile seizures. Understanding the clinical presentation and diagnostic criteria for complex febrile conversion is crucial for appropriate management and counseling of family regarding prognosis and risk of recurrences. So lesson diagnosis of complex febrile conversion. Complex febrile seizure always requires specific investigation, e.g. imaging the last longer than 15 minutes, have more than one seizure within 24 hours, recurrence that pronounced one side of the body, transient speech impairment, and heavy paralysis determine the cause of fever, as in which simple febrile seizure perform puncture to exclude meningitis and herpes encephalitis. EEG, imaging, CT or MRI. Make like clinical people always need EEG and imaging for cases that pronounced on one side, transient hemiparesis, speech impairment more than 15 minutes, more than 1 per 24 hour. Typical age is not between 6 months to 5 years. Febrile seizure are considered complex if one criteria is met. Complete febrile conversion symptoms seizure associated with fever over 38 degree without evidence of intracranial infection or defined cause, and duration less more than 15 minutes. Recurrence may occur within 24 hours or same paralysis. Vocality have focal unicellular picture indicating specific region of brain is initially involved, and pathophysiology and historic detailed account of seizure, including onset, duration, and any focal feature information on the level of fever, recent illnesses, and family history of family seizure. Febrile seizure or epilepsy is crucial physical examination and laboratory tests, blood tests, including electrolyte, blood glucose, and complete blood count to exclude metabolic causes, lumbar puncture if meningitis is suspected, and imaging, neuroimaging, MRI, CT is not routinely recommended. EEG is not typically used for diagnosis. Acute management. Seizure management with antipyretic to manage the fever, and if necessary, rescue medication for prolonged seizures such as reptadiazepam, carbimazole, and long-term management not usually require unless there is underlying neurological condition, and prognosis risk of recurrences and developmental epilepsies. And high-yield polycomplex febrile conversion are characterized by duration over 15 minutes, recurrence within 24 hours, or focal feature diagnosis is primarily clinical, supported by history and physical examination investigation aimed at ruling out other causes. Long-term and epileptic treatment not typically indicated.